Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach. We have the pleasure today of having an old-time user of this platform, Nourou Bankole, a neurosurgical resident from Morocco, as well as some panelists, mostly from Africa. Let's first go around and meet the panelists. Okay, let's start with you, Ulrich.
Yeah, so.
Can you get off the screen share for a second, Nourou, so we can?
Right.
It's all right.
It's all right. It's all right.
Okay, go ahead. Go ahead, Ulrich. Please introduce yourself.
Yes, thank you, John. I'm Ulrich Sidney. I'm currently a research associate at the program Global Surgery and Social Change at Harvard Medical School. I'm equally the founder of this group, the Association of Future African Neurosurgeons, and I'm pleased to have all of you here. Nice to meet you.
Okay, Ulrich, I'm sorry. I should have introduced Sublime first. Hello, Sublime. How are you?
Fine, thanks.
Could you please introduce yourself, tell where you're from, what you're doing, etc.?
My English is not perfect. Huh?
That's okay. That's okay.
Okay, my name is Siblim Chamala. I'm from Congo, DRC, and I'm resident in Morocco in neurosurgery.
Very good. Welcome.
Thank you.
Dr. Douai?
Oh, my name is Amadou Douai. My CTA medical student at the University of Boya from Cameroon.
Very good. Welcome. Okay, and do we have anybody else here that is on? Okay. Yeah. Anyone else hasn't been introduced? Najadia, can you hear me okay? Najadia? Let me unmute you there. There you go. There you go. Okay, let me unmute you here. Come on. Can you unmute yourself, Najadia? There you go. There you go. Okay. There you go. Go ahead. Oh, I'm sorry. I muted. Go ahead. Go ahead.
Hello, everyone. I'm Jaja. I'm a third-year medical student at the Faculty of Health Sciences at the University of Boya, Cameroon.
Oh, great. Welcome. Welcome.
Thanks.
Okay, Nourou. Oh, no, there's one more. Augusto, could you please introduce yourself? Yeah, unmute yourself there. I'll try it here. Not being very responsive. There you go. Okay, go ahead, Augusto.
Don't let them make you regret it.
My name.
Don't let them make less out of something that means so much to you.
Okay, go ahead, Augusto. Go ahead.
My name is Augusto Jacinto Mucinza Alberto. I am resident for neurosurgery in second year in Maputo Central Hospital.
Oh, wow, that's great. So thanks for coming by. Okay, Nourou, welcome and thank you. And please say a few words about yourself and then on to your introduction, also into your presentation. Thank you.
Okay, thank you, John. I am Nourou Bankole. I am resident in neurosurgery here in Morocco. So it is a pleasure for me today to join with you, to chair this journal club with you. So welcome all of us and nice to meet you all. So I will start. Today we would like to present this article who was published this year in British Journal of Neurosurgery. And this article talks about the effect of an additional neurosurgical resident on procedure length, operating room time, estimated blood loss, and post-operative length of stay. So it is one article about this team of Texas, Dr. Anthony. So neurosurgical residency training is costly, with expenses largely borne by the academic institution that train residents. One expense is increased operative duration, which leads to poor patient outcome. Although other studies have assessed the effect of one resident assisting, none have investigated two residents. So we sought to investigate they start to investigate if 2 residents versus 1 couple in impacted operative time, estimated blood loss, and length of stays. So it was a retrospective review of patients who underwent a neurosurgical procedure involving 1 or 2 residents between January 2013 and April 2016. So this team, they performed multivariable linear regression to determine if there was an association between resident participation and case length, operating room time, and estimated blood loss and length of surgery. So they also included patient demographic, attending surgeon, day of the week, time, preoperative LOS, procedure performed, and other variables in their models. So only procedure performed at least 40 times during the study period were analyzed. So the result, it was about 860 procedures that met study criteria. 492 operations were 1 of 6 procedures performed at least 40 times, which were anterior cervical discectomy and fusion, cerebrospinal fluid shunt insertion, CSF shunt revision, lumbar laminectomy, intracranial hematoma evacuation, and non-skull base, supratemporal parenchymal brain tumor resection. An additional resident was associated with 35.1 minute decrease in operative during for lumbar laminectomy. However, for intracranial hematoma evacuation, an extra resident was associated with a 24.1 minute increase in procedural length. So here, there were no significant difference observed in the other 4 surgery. But when you see this table, they publish, this is one table who described statistically the qualifying surgery involving 1 or 2 residents. Like you can see here, I will not comment all the topic, but what make me, what catch my attention is this. When you can see here, when 1 resident perform the number of cases, 227. And 2 residents together, it is 265. So CSF shunt insertion, that you can see here, they perform craniectomy for hematoma evacuation, just 28 cases. But in 2 residents, we can see here, 64 cases. So for the purpose, the study, a senior was defined as a resident at least in the 5 years of neurological surgery. The length of stay is defined as total time in day the patient is in the hospital. Procedure length is defined as time in minutes from scan incision to closure. Total operating room is defined as total time in minutes the patient is in the room. And estimated blood loss is defined as the intraoperative blood loss estimated in millimeters. So like you can see here, and it is sample size, and it is the standard deviation. This is another summary including the MC fed and pseudo as an approximation for validation variation explained by the model of multivariable linear regression for all outcomes. So you can see here significant variables is certain day of week, patient sex level, and surgeon number of resident experience, surgeon with patient age, surgeon day of week, total room time. So all these parameters, parameter was studied by this time, because by this team, and like you can see here, the number experience of most junior level was divided into 2 groups here. A positive coefficient indicated that there was greater length of time of blood loss in the group where the most junior resident was PGA residency number 5 or above. A negative coefficient indicated that there was a greater. So like you can see here, if you take the number of residents, procedure length, you have more 50.8 minutes more. Room time to 22.5 minutes. Estimated blood with 8.6 millimeters. Posterior laminectomy, you can see here procedure length. It is not the same, it is down 35 minutes. But when you see, if you take experience of most junior residents to compare, you will see here, he will take more times about the procedure length. He will take more time about, you can see here, estimated blood loss. So you can see here, to compare to the estimated blood loss, you can see here just 8.6 resident, but of the most junior resident, you can see estimated blood loss is very high. And another parameter, so I think I will go ahead. Okay, it is the same here. So as if always when you take the procedure length, like here, about cranio for hematoma evacuation, the number of residents, you can take just 24 minutes to evacuate hematoma. And the most junior resident, like you can see here, it's always take longer than the resident normal, postgraduate. But I think it's not here. Okay, so I will go to discussion. So I think that this article, simultaneous training to neurosurgical residents in the operating room may not negatively impact patients or incur extra cost to academic institutions compared to allowing only one resident to scrub in. This may represent a more effective way to train neurosurgical residents given the current landscape of surgical education and the decrease in resident independence within the operating room. Additional prospective studies are necessary to elucidate the nature of the association between number of residents and both operative length and time spent in the operative room. Perhaps more interesting is the association between outcome and resident experience level. Because like I showed in this table, I will recommend you to go to read and to see that correctly, to analyze that well. Like you can see, more you have experience in your curve about your curve learn in your procedure. It is better for the person because you will not take longer about your procedure. You will lose more blood because you have experience and you can go so fast than the young resident who will done the case alone. But when the least experienced resident was a senior, you can see estimated blood loss was increased. Like example about this anterior cervical discectomy fusion and decrease in CSF shunt revision. Procedure length was decreased in lumbar laminectomy and increased in intracranial hematoma evacuation. And total operating room utilization was longer in hematoma evacuation. Maybe sometimes we take more times to do well the procedure to avoid some complications that we know with experience. But the young resident, maybe they don't have more experience to deal with complications after surgery, to take care about hemostasis, what you have to do, many things. Senior resident priority in selecting cases may be a contributing factor, and complexity of hematoma may also affect the association observed. Another possibility to consider is degree of operative autonomy, because it's very important about the autonomy that you have to operate some case. And attending surgeon may be more willing to allow greater autonomy in a safer case, such as anterior cervical discectomy and fusion. However, autonomy of neurosurgical resident has been affected by recurring that attending surgeons are in the operating room and scrabble in for all critical portions of a case. There are several important limitations of the study. You have to know, because this study, we will comment that together so soon, but it was the retrospective, they have retrospective nature limits the ability to determine degree of resident involvement in surgery. It is very important, but here we don't have that. Furthermore, although procedures were grouped by similarity, complexity due to more intricate details such as anatomic variation or location of pathology were not controlled. Additionally, difference in individual resident scale could not be accounted in this study. In conclusion, an additional resident may lengthen duration of intracranial hematoma evacuation. However, 2 residents scrubbed in were associated with decreased lumbar laminar duration. Overall, an extra resident does not increase procedural duration, total operating room utilization. Allowing 2 residents to scrub in may be a safe and cost-effective method of educating neurosurgical residents. So thank you for your attention, and I wait for your comment. Thank you, everyone. So it is article.
Okay, Nourou, thank you very much. I'll let Ulrich lead the discussion. Go ahead, Ulrich.
Yes, thanks, John. Thanks. Hello, everyone. So we have a sort of guidelines for a journal club, and we will, let me just get this on the screen so that we can share it, so that we can try to follow this.
Okay, you need to get off screen share, Nourou, I think.
Oh,
yes.
Wait, just give me a minute, John. Let me find this real quick, and then.
Okay,
yeah.
Very good. Okay, so you went to China. Did they have a good crowd there, Nourou, in Beijing?
You say what you say, John?
Did they have a big crowd there in Beijing? A lot of neurosurgeons?
Yes, yes. It was 4,129 participants.
Wow. So you met a lot of people from all over the world.
Yes.
Okay.
Yeah, I'm good to go.
Okay, go ahead.
Yeah. Thanks, John. Sorry, everyone for the delay. Thank you so much, Dr. Nourou. Very good work there. We had this from Dr. Kabulo, and this is very helpful. Every time we want to discuss an article.
Okay. Yes, you are right. I didn't follow that. Yes, of course I don't. I told you before to start that I didn't follow that, because I just made one summary, and I would like we discuss that directly. But you are right. I didn't follow.
So
yes.
What we it's absolutely okay, Dr. Nourou. Thanks for doing this for us. What we like to do is try and follow this schema so that we can all go together. And I find that there's a few people that came. Please feel free, say whatever you think. This is the forum. This is the opportunity for all of us to learn from one another. So,
yes.
So don't worry, everyone chip in. Don't worry about anything. If you don't understand the statistics, ask the questions. If the English is too complex, we can always break it down. So ask your questions. Feel really free, please. So the very first thing is this study research question relevant? Dr. Nourou did a great job explaining the summary like about this article, but do we feel like finding out what the impact of having a second resident in an operating room does to the operative times or blood loss, is that question relevant? This question is open to everyone. Please feel free.
Excuse me, Dr. Sydney. Hello.
Hello.
Go ahead.
Yes, hello everyone. Yes, it's Zulu. Yeah, please, I would like, is it possible for you to repeat the question, please? I did not get it.
So the very first question is this one. Yeah. Can you see it?
Is the study research?
So is a study's research question relevant? Because the study question is trying to find out what the addition of a second resident does to operative times and intraoperative blood loss. So do you feel this is a relevant study question?
I think you have to answer yes or no, I think.
Yeah, well, anyone.
Yes, I believe it is certainly relevant to see how it was interesting to see the difference in the blood loss and the time. Those seem to be the two factors that were judged.
Yes.
Some were more blood loss, which I kind of wanted Nourou to try to explain why certain procedures with two residents there was more blood loss, and some there were less and less time with certain procedures. Because I'm not a neurosurgeon, I don't know what's involved in a specific operation.
Yeah. I mean, you're right, John. Dr. Nourou and the article alluded to this, right, guys? So most of us right now are either residents or willing or aspiring to be residents in neurosurgery. So the question for you is, say this, given the response you have from this article, you can basically justify whether you should find yourself scrubbed in or not scrubbed in for a case, right? So you go for this case and you find there's already another resident. The question we're trying to find out is, does adding you in that case, having you scrubbed in for that case, does it do any good? So come on, guys, tell me, what do you think? Is this relevant for you?
If I believe if those who have already scrubbed in, if we can handle the situation, I don't see the importance of.
We can't hear you. Your microphone, Zolo. Your microphone.
Yes. Are you getting me now?
That's better.
Yes. Okay. So what I'm saying is that if those who have already scrubbed in can handle the situation, I don't see the necessity of adding another resident to it. You can just stand by and observe, but not it doesn't need to scrub in if those who are already in can handle the situation adequately.
Okay, Zolo. Good. Dawai, you wanted to say something? Yes, Dawai.
Yes, I think a pair of hands is always helpful.
Yes.
Though it may be that, as Zolo said, if the people that have already scrubbed can handle the situation, there is no need for more. But let's not forget that the person that will add to the procedure will learn more, and the patient may benefit from it. A pair of hands, I think a pair of hands is always helpful.
Okay. So thank you so much, guys. Both of you made very, very important points. So questions to elaborate on what you said. So Zolo, you said if those who are scrubbed in can handle the case, then no need for a new case. Very valid. So what do you think helps you decide when a case can have another person? How do you decide if a case needs another pair of hands, Zolo? What do you think?
I think the titular, if I can put it like that, is the boss, if I can put it like that, is the one to decide if, given that he knows what he's going in to do, he's the best person placed to decide if he needs another pair of hands to help him.
So what you're saying is complexity, right? The complexity of the case.
Yes,
okay.
Actually.
How about the experience of the person coming into the case? If you were the senior surgeon, would you take into consideration whether the person has experience with these cases or not. Would you take it into consideration?
Yeah, I will take into consideration. And if I find out that, that's what I'm saying, that if those who have already cropped in can handle this.
Okay. I would like to comment what you said, guys, about all your
situation according to how. But if I feel or I find that then I can allow it.
Okay. Yes, Dr. Nourou, go ahead.
Okay, thank you, guys. So I understand what you said, but you have to know this article that we chose to try to analyze and to take out one message for all of this. It is that in this article, they take some procedure, not all procedure we done in neurosurgery, okay? And all of this procedure you will see, it is an emergency, it is neurosurgical, it is emergency. Just one case where you have anterior discectomy and fusion, cervical anterior discectomy and fusion. You can have that in traumatic or in degenerative case about spine, okay? But evacuation of hematoma, it is an emergency case, okay? Hemorrhage spontaneous or laminectomy, maybe for spinal cord compression, echinocoda syndrome. So all this procedure, it is for the resident who has done his shift and he has this case, have to take the patient to go to operating room to operate them. Of course, about insertion, about the drain of CSF, they can see if you take care, you will see that if you have two residents, they take a long time to done procedure, but it depends also which shunt, external shunt or internal shunt, because from my experience, I know that external shunt may be so fast, just with one resident, you made your borehole, when you will be two, maybe you have to, if it is young, then you have to explain to him, you have to do like that, you have to do this. Yes, of course, you will take more times to done your insertion of your catheter intraventricular. But about internal shunt, like ventriculoperitoneal, you have two residents is better to make it quickly because only one resident can't do that so quickly. No, it is impossible. I think depend the procedure, okay, and according to the guideline about because
So, Dr. Nourou,
in residency course, yes.
Yes, absolutely right. Before you're already discussing the case, before we get to the case, let's try and see what before we get into the paper in itself, let's try and get everything that's around and then try and get everyone in it. Yes, we're not discussing the paper yet. We want to see and then try to understand. This way we'll understand why the methodology was right and which things were lacking.
Okay, go ahead.
Okay. So absolutely right, Dr. Nourou. So the way you guys said it is, from one point of view, is we would like to know if it's necessary. But on the other hand, someone raised a really important point, was if you get someone else, then this person can equally learn. So that's where we find ourselves, and that's how we can justify this study. Because if you have your residents need to learn. Right? They need to learn, so they need to be scrubbed in. They need to see these things. And we know in neurosurgery, it's not about the books. It's not about saying it. But on the other hand, like Dr. Nourou said, sometimes adding another hand can make things more complex. And that can actually make it difficult for the surgeon, but equally for the patient. The patient might be exposed to more danger. So now we might understand why these people thought, the authors thought, well, if we're thinking about the patient being in danger and that the patient is find himself longer in the OR, then that means more anesthesia. But then they thought about blood loss as well. So they thought if the patient is losing more blood, if the patient is losing more blood, then the patient is more exposed. So this is where you find yourselves. This is where we find ourselves in terms of this study. So the next thing is, do you think this study added anything new to what you know? Once you've looked at the study, do you think it added anything new? Let me remind you the conclusions from the study. So the conclusions from the study was, we had a few groups, right? We had ACDF, anterior cervical decompression with fusion. We had a few emergency cases, and Dr. Nourou spoke about this. And the results were comparing not only the time in the OR, the results is equally took into consideration the experience of the most junior resident, right? And they equally took into consideration blood loss. So what you want to ask yourself is, before you read this paper, what did you think the result would be? If I asked you, I have a second resident, what would you think the length of the intraoperative time would be?
Yeah, I was surprised to hear that it's more complications when there's two in some cases, or more. I was surprised. You would think another set of hands would speed things up and have less complications.
Yeah, you're right, John. Yeah, you're right. So that will go into when we get to that discussion. We need to find out, why was there this difference, right? What can explain this?
Eric, I'm sorry I think obviously if you had two residents, that's not mean you will have complication.
Exactly.
It's not like that. But what they try to show, it is for some cases, it is about what operative length, most blood loss, and I think they also let me see. Oh my God, what happened?
So let me help you with this. We have it here. So the major results, right? The major results.
Yes.
We had 860 procedures that met the study criteria. 492 operations were one of 6 procedures performed at least 40 times.
Yes.
We had anterior cervical discectomy and fusion, CSF shunt insertion,
yes,
CSF shunt reversion, lumbar laminectomy, intracranial hematoma, non-skull base, supratentorial parenchymal brain tumor resection. An additional resident was associated with 35.1 minute decrease in operative time, right?
Like in lumbar laminectomy.
Yes, for example.
For example, but in intracranial hematoma evacuation, you will see that they have increase of 24 minutes.
Yes.
In the procedural length. So for me, it is not about complication. It's not about complication of no. But what they try to show it is sometimes you need to go. You need to go fast. Sometimes the new resident have to know what it is benefit for him when he come in operate room. When you come, you are young resident, you come in operate room. What you have in your mind, you know that maybe you will not do some procedure, you will just be there to see, to learn, and to help the resident senior to go fast and to operate correctly. So this, for me, this paper, for me, I will not say that is add something new about my practice for me.
Okay.
And this study have many limits. It is.
Yeah, we'll get to that. So what type of research question does the study pose? What kind of research methodology wise, what do we have here? Hello, everyone.
Well, yeah. Me being a non-neurosurgeon, why, with two residents, there's more. It prolongs the case, it seems, in some cases, correct?
Yes. Well,
I can't understand why that would add time. Having another set of hands.
So, again, we'll do that. Like, once we dissected the type of methodology, we'll be able to find that reason.
Oh, okay.
Because because depending on the kind of research method you choose, then you can have different forms of interpretation. So certain research help you get association, correlation. Others help you get causation, and that way you can be able to say, well, X is the cause of Y. Otherwise, you just have association and you have confounders. We'll get to that complexity after. So, what type of research question does the study pose? Zolo, what do you think?
Go
ahead, Zolo.
Yes, I actually think this was not time to
your microphone, please. Your microphone. Zolo, your microphone.
Yes, I came late, so I did not have time to read over it. And the article I had, I read another article. So.
Oh, okay.
Yes, I read the article which was on I think infection and.
Oh yeah, shunt infections.
Yes, me too. That is what I prepare, but I see that in another. So, but
okay,
I'm just trying to get what we think here.
Okay, it's a communication issue. So, sorry about that. It was a miscommunication. So, coming to what we're asking about the question, the types of question we're trying to find out. To put it really simply, we're trying to find out, okay, having a second resident, a second pair of hands, like we said, versus one resident, and trying to find out what the outcomes, how the outcomes are modified, right? So if you're looking here, would you say it's more about effectiveness of treatment, or it's more about frequency of events? Where would you put it?
Perhaps Dr. Kabulo, who's just arrived, has the comment. Hello, Dr. Kabulo. Maybe you have a comment for what Sidi just mentioned.
Hello, Dr. Bennett.
Hello.
Hello, everyone.
Hello, Dr. Kabulo.
Welcome, Dr. Kabulo.
Thank you so much, Dr. Nourou. Thank you, Dr. Ilrik. Dr. Zola, how are you?
Fine. We are doing well.
Sorry, I'm late today. I just arrived 30 minutes ago. I was in a town like 400 kilometers away from Harare. I was in Bulawayo. We had the AO spine course for the past 3 days. So I just arrived.
Welcome.
Great.
Welcome.
Thanks.
Welcome.
Go ahead, Ulrich.
So, I'd say for the studies, just to help everyone out and have everyone on the same in the same wavelength. So when you're looking at the hierarchy of research questions, research study designs, right? You'd see you can move all the way from below, like expert opinion, all the way to randomized controlled trials. Whichever research study design you're considering, you should know what are the advantages and the disadvantages, and as well as which are the biases inherent to each study design. If you know that, then you can always refine your question, because it is important to know, it's not because, for example, a research is a randomized control trial that the results of that research are both case control. If the randomized control trial wasn't done respecting the guidelines of randomized control trials, then you wouldn't be able to use his results, right? So you equally need to know about these study designs. So if you're not using, if you're trying to get just an association or correlation, any study below the randomized control trial helps you get that. It helps you get that association or correlation. Don't speak about causation. You cannot use anything other than the randomized control trial in this case to speak about causation. Why is this the case? Because when you're not randomizing, you have inherent biases, like selection bias, for example. You've got confounders, and all these things make it difficult for you to have a just interpretation. So for example, in this article, if you went and said, oh, we added a second pair of hands, a second resident, and the time for the operative time has increased, so second residents increase the operative time, there's a problem, because something else might explain that. It might be the fact that every time you called the second resident, it was because it was a complex case. If every time you call a second resident, it was a complex case, it's normal, it's logical, that will be, the operation will be longer. But that doesn't mean that having a second resident in your case necessarily causes an increase in the operative time. So how would you stop that? You'd need, for example, a randomized control trial, which would, by definition, randomize your study population, making it such a way that this study population shares the criteria evenly. And that way, all you're evaluating is the cause and the effect and seeing whether there's a relationship. So for each type of study design, you should always, always know which are your inherent biases and what can you learn. So in our study, our author said, let's go and study the correlation, the association. How did they do this? They use regression. So for those who are not used to regression, we can simplify regression to 3 types of regression, right? You can have linear regression, logistic regression, or Cox regression. These are not complicated. And this is why we have this session, to try and all understand these things. Let's put it simply. If you're talking about linear regression, you're opposing one variable which has numeric values to another variable which has numeric values. Example, you're opposing temperature and blood pressure. Temperature, you have values, right, in degrees Celsius. Blood pressure, you have values in millimeters of mercury. So that for a study about correlation there, you'd use linear regression. Now, if you have one of the variables that's not expressed in terms of numbers, but in terms of, say, words, I'm putting that into quotation. What do I mean by words? Say you're saying the gender, male and female. Say you're saying you want to compare the races of people. You say African American, black, white. Now, when you have that kind of a case, you cannot use linear regression. What you can use is proportions. So you can say for every patient with the temperature of 37 degrees Celsius, I had 30% who were Caucasian, 90%, I don't know, who were black, for example. So in that case, in terms of proportion, you'll be using logistic regression to find a correlation. But when you say Cox regression, this is for what we call time to event. So time to event, a lot of us know it as, for example, when you speak about the Kaplan-Meier curve. What does this mean? If I decide to study recurrence of a cancer, for example, of a tumor, what I will do is, for all my patients, I will follow them, and when they have regression, I will say, oh, this is when they have the regression, and I will put the time on a map, and then I'll take all my patients and draw it. So I will end up with a sort of staircase diagram. Since everyone can see my screen, I'll just look for Kaplan-Meier and make a better explanation. So let me take this, for example. So this is, let's take something very simple. Okay, so say I'm following my patients. All my patients here I'm studying regression. All my patients here have not had regression. So during this time period, call this maybe 1 month. So at 1 month from this graph, at 1 month, 100 of my patients, no one had regressions. And then at the 1 month mark, I had 10% of them who had a regression. So I'm not at 90, and so on and so forth. So for this kind of an event, for this kind of data, you would use Cox regression to find out the correlation. When you're using regressions, the answers you're going to get will be in terms of confidence interval and odds ratios as well. So not just correlation, you have confidence interval and odds ratios. So now that this is explained, like really in summary, what kind of study design do we have in this paper? Is it a case control? Is it like a cohort study? Is it a randomized control trial? What kind of study do we have? Is it a meta-analysis? Hello?
Yes. Your sound is going, Ulrich. Hello, Ulrich. I think you're.
Hello.
There you go. There you go.
Yes.
Okay.
So, oh, someone sent them. Someone sent. Oh, so anyone want to contribute? What kind of study design did we get here? Okay,
I wish you could
back.
comment. I wish you could comment, but I don't really know much about this at all.
No big deal, no big deal, John. I'm looking at my junior guys there. Zolo, I'll be picking on you today. So let's start here. So this is definitely not a systematic review, right? We're going to go by elimination. This is not a systematic review because we all know, right? You take a number of studies and you start evaluating them, right? You go and do a very systematic review of the literature, and then you eliminate some papers and you go down. This is not a systematic review. That's not what we're doing here. Not a meta-analysis. This is not a randomized control trial. There's no intervention and randomization of the patients to an intervention group and a control group. So this is not an RCT. Okay?
Okay.
Okay. So do you think it's a cohort study? Anyone? Do you think it's a cohort study?
Well, Zolo, you're on the hot seat.
Zolo's my guy today, so he's not leaving, right?
Oh, that's right.
I think it's one.
Go ahead,
Your
Zolo.
microphone.
Yeah, adjust your mic, Zolo.
Yes, I think it's an observational study. They went in and they observed the duration of operation with an additional of another resident. So I think it's an observational study, and is some sort of, I can say it's a cohort study.
Okay. Anyone agrees with Zolo or doesn't agree? Oh, guys.
Well, yeah, you're getting dead air. I call it, Ulrich.
Okay.
Can you comment, Dr. Cabullo? I think most of the panelists don't know about all these differences between the studies.
No, it makes sense. It makes sense, and this is why we're here, right? This is why we're here. So what we want to know is what's the difference? What's the difference between a cohort study, right? A case series, for example, a cross-sectional study. Yeah, go ahead.
So in a cross-sectional study, it's like they follow the proportion. They come at a particular point in time,
yes,
and you take the proportion of an event, a disease, or I don't know, whatever. So you come at a particular point in time and you make a study.
Yes.
And you get your values and your interpretations and your conclusions. Meanwhile, in something like a longitudinal study, like you follow up the patients, or you follow up the people coming into play in the research over a period of time. Then you can now make some interpretations of whatever value you have. And in retrospective study, as the name indicates, is also a form of I don't know if you can say longitudinal study, but there you are looking at what events that have already happened in the past. So you are no more like trying to follow up patients. You are trying to look like the events that happened in the past and how they affected their present lives. You can put it like that.
Very good. Very good, Zolo. Very good. Now, I'm going to give you a tip now. This study, right, which was published in 2019, look at what they did. See, look at what they said. In this retrospective review of patients who underwent a neurosurgical procedure involving 1 or 2 residents between January 2013 and April 2016. So you said it yourself. If you're having a cross-sectional analysis, then it's sort of a snapshot, right?
Yes.
Okay, and then you defined your cohort studies. You spoke about the retrospective aspect, the prospective aspect. Where do you think this study finds itself?
Eventually, it is a retrospective study.
Very good, very good. Why is this important, guys? Why is this important? Because for each type of study, there are guidelines that you must follow, that you must obey. And for each type of study, there's a type of this biases you must avoid. So using this again, so if you're saying this word you see here on this paper, this is what you need to read it. And thank you, Dr. Kabulo, for making it available to us. When you say you're doing a randomized control trial, this is what you're supposed to. This is what you're supposed to do. Look at the consort guidelines. If you're looking at cohort, you're going to look at things like the strobe, the consort. Oh my goodness, the consort guidelines and the strobe guidelines for observational studies. So for each type of study, you should know which are the guidelines. You should check those guidelines, even when you're reading or when you're designing the study. Check the guidelines and see if they're respected. So observational study, strobe. If you're trying to do it, if you're trying to study an observational study, always go back to your strobe guidelines. And by doing this, you would be able to see which are the strengths, weaknesses, limitations of the paper, and to see whether you should be able to use the conclusions in your practice. Okay? Right. So now that we've spoken about the study design, we can go to the next question, which is, was the study performed in line with the original protocol? What did the authors tell us about how they expected to do the study? It's in the paper. If you check, like, okay, let me show it to you. Everything is highlighted. Okay, so we reviewed patients who underwent a neurosurgical operation between January of 2013 and April of 2016 at our institution. We included cases in which 1 or 2 residents were scrubbed in. So this is what they're supposed to do. Operations with 2 residents were included. All this is the theoretical. Why did they do this? Well, now, criteria of exclusion. We excluded cases in which multiple attending surgeons scrubbed in, as these were likely either highly complex cases or cases requiring multidisciplinary panels to perform separate procedures. Also, we excluded the cases involving incarcerated patients. So they've given us that the inclusion, the criteria for inclusion and the criteria for exclusion. When you looked at the description of the cases they had in the results, did you find that they actually respected what they had set out to do? It's a very easy question.
Can you just, since I don't have the article, can you just scroll up? I would like to see the results.
These are the results here. These are the results. Hmm?
Yeah.
So this is it. Yeah.
Yes, I think they respected the criteria of they respected the protocol they put in the beginning.
Yes, yes, you're absolutely right. So it's not complex. Why is this important? Because if you set out to do one thing and you don't do it, say you had a protocol, you calculated, we needed for this study to be powered, we needed 500 cases, and you come up with 400 cases. Now you're not respecting the protocol. If you said this was the exclusion criteria and you start putting the excluded criteria into the cases which have exclusion criteria into your cases, then you're not respecting protocol. All these things change. If you decided to do a randomized control trial and you said we randomized to treatment and no treatment, and at one point in time, you said it was double blinded. So you didn't know where the patients found themselves, the patient didn't know where they found themselves, but you started telling patients what they should do, telling them, no, you should get the treatment or don't get the treatment. You're not respecting protocol. So always look out for these things. Always look out for them. Okay. So Does the study test a stated hypothesis? So, did they start by telling us, oh, we believe this might be the case, and this is what we're going to look at. Did you feel like there was a hypothesis here? Here's the introduction. Here it is. My friend Stefan, if you have anything to say, come on, say it.
Let me. I want. Hi everyone. I just want to take the train on the road.
Okay.
I didn't understand yet where we are.
So we're trying to find out if there was a stated hypothesis.
Before talking about the hypothesis, the question above, I want to say. I want to know why they. Zolo, please mute your microphone.
Sorry.
I wanted to know why did they put in the final analysis only the procedures who was made at least 40 times.
Yes, exactly. Look.
Understand why.
Stefan, good,
yes.
Good question. And all these things we'll dive into them. We'll dive into them at the very end. Before you start, this is why these steps are important. Before you start going into the methodology, you have a very valid and very good question. Before you get there, you need to know, because knowing if there was a stated hypothesis is important in the sense that you have a null hypothesis and an alternate hypothesis. Whatever they chose after that, if they didn't do this in the beginning, or if you don't feel like there's this in the beginning, then there's a problem. So we will get there. Keep your question. I promise, my friend. We'll get there.
Okay.
Yes, we will get there. So what was the hypothesis here, according to the authors? So you get a sense. You can get a sense if you read here. They give you that position. What was out there before coming to a conclusion. So if you come here, they tell you that in one previous study, adult neurosurgical cases involving residents took longer. That's one thing that was out there. So why the association between resident involvement and patient morbidity and mortality is currently an area of debate due to possible confounders. Remember this word, confounders? There's much existing literature that describes increased complications with longer procedures. The inherent complexity of many neurosurgical procedures, blah, blah, blah. What does it lead to? 80-minute longer and 80-minute longer procedures. So each time, what comes back? The fact that the procedures are longer.
Longer.
Right?
Yes, yes.
So they let you know this is what they're looking at. Look, here it is. Involving residents, procedures took 34 minutes longer. Blah, 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 80 minutes longer. That's where they want. And they come and conclude here. Look at the conclusion. Very clear. We aim to investigate whether 2 residents scrubbed into a case was associated with increased intraoperative complication rate, procedure length, and patient length of stay. Time. Longer. So this was the hypothesis. And your null hypothesis, what would be your null hypothesis here? If you think it's longer, what would be a null hypothesis? So, hypothesis here, let me restate it. Having a second resident scrubbed in leads to this, to more intraoperative complications, to increased procedure length, and to increase patient length of stay. So what is the null hypothesis? Zolo, once again, go ahead.
Poor Zolo.
Nah, he's my. I'm
your whipping boy.
Yeah.
Hello, Dr. Ulrich. Sorry, my connection went off. Can you just explain back the chapter you just you highlighted, please?
Yeah, so we were just talking about the hypothesis, right? The hypothesis here is we want to show that there's increased associated, there it is, here.
Yes.
Aim to investigate whether 2 residents scrubbed into a case was associated with increased intraoperative complication rate, procedure length, and patient length of stay. This is it. This is the hypothesis.
Yes.
Yes?
Yeah.
Okay, so what is the null hypothesis in this paper?
The null hypothesis is that adding like two residents scrubbing in is not associated with an increase.
Very good. Perfect. Very good. Is not associated with increased intraoperative complication. That would be the null hypothesis. Perfect. Great. So we agree that there's in this study there's a stated hypothesis, right?
Yes, yes.
Okay, and we know the null hypothesis. This is important because when you do statistical hypothesis testing, what you're testing is the null hypothesis, right?
Yes,
and, yes, you're testing. When you speak about things like statistically significant, what you're testing is the null hypothesis. You're testing whether to reject the null hypothesis or not. And this leads to the concept, very important concept of error, type 1 errors and type 2 errors. Very, very important concept. To make it really simple, when we speak about error, you guys will hear these words about error, about the other thing is power. Yes, power. So when you say you have a p-value or an alpha of 0.5, when you say it's 0.5 your null value, what do you mean for your p-value? I mean alpha. All of us have said something is statistically significant. What do you understand when you say statistically significant because the p-value is less than 5%, less than 0.5? What do you understand by that?
I think yes. That 95.
We can't hear you, Zolo. Go try again.
No, I think what you want to say about p-value is if it is reproducible, your result. If you have p-value significantly, that means your result is reproducible if you take another series.
Okay.
The same studies, that means you can your result is reproducible.
Okay. Okay. So you hit it on the head there. So what you're trying to say here is when you're talking about the p-value, and this will lead into why most papers now are speaking about dropping the p-value and going towards the confidence interval. So when you're using the p-value, if you say you set your p-value at 5%, which is what most people do, and I'll explain to you why 5% and why you can change it. If you set it at 5%, what you're saying is you're testing the null hypothesis. Remember the null hypothesis in this paper. Zolo, remind us, what was a null hypothesis?
Yes, our null hypothesis is that adding 2 residents does not increase the duration of
exactly. So having a second resident does not increase. That's the null hypothesis. If you're testing the null hypothesis and the p-value is less than 5, what it means is you finding that result or anything just as unlikely would be less than 5. So you have less than 5% of that chance of finding any other result than that. So basically, in this case, you'd be in favor of your H1, which was increasing a second resident into the OR will lead to increased time, increased complication, increased blah blah blah. So why 5%? 5% was chosen because before we started having STATA, SPSS, EPI info, EPI data, all those packs, what people would do is they use tables to know what the p-value was. And when you're doing this, when you're using tables, you have 2 things you can come up with. Either you're doing it with what we call the normal distribution or Gaussian distribution. I know everyone knows this thing. It's like sort of the bell curve shape. When you use that, you have what you call the central limit theorem. To make it simple, 95% of values find themselves within plus or minus 2 standard deviation. So if you have the value, let's call it 10, the standard deviation is 2. You will say 10 plus 2 times 2, 2 because of the standard deviation. So from 10 minus 4 to 10 plus 4, so from 6 to 14, 95% of your values find themselves there. 95% of your values find, if you are talking about a normal distribution. So because there was that link between 95, which is the 5% level, and the 2 standard deviation, that's why it was adopted. But you can change that. So if you're doing a study, you can change your p-value to be statistically significant to be less than 5%. Some people can go to 1%, others can go to 0.5%. So your p-value is not always 5%. But the more you reduce that p-value, the more you make it unlikely that the null hypothesis is right. Okay?
Mm-hmm.
So in this paper, what was the p-value our authors decided to use? The p-value is here. Look at it, alpha, right? Here is alpha, 0.05. So 0.05 is 5%, okay? This is it. This is what they use, 5%. Now, going on to the next thing. A few papers like New England Journal of Medicine are saying they don't want to have p-values anymore to be reported. They want other forms of information like the confidence interval. Remember, I spoke about the link between the p-value and a normal table and 95%. So when you say confidence interval at 95%, and you're talking about a p-value at that level, which is 5%, you have that link. So, but the confidence interval doesn't just give you an idea of the p-value, it equally gives you an idea about the standard deviation, which means the confidence interval gives you more information than the p-value. So if you're writing today, please be careful when you're submitting your article. Does your journal still accept you reporting p-values? Very important. So no need to report both the p-value and the confidence interval. So that was about that question. The next one is, were the statistical analysis performed correctly? I explained already here about regressions. So I'm expecting from you guys, what would you use in terms of, what kind of regression would you use here? Would you use a linear regression, a logistic regression, a Cox regression? What would you use?
Come on, Zolo, you're the answer, man. Any comments, Zolo, at all? I think he's...
Okay, no big deal, no big deal.
Okay.
No big deal. So just remember once again, if you're trying to use linear regression, you have variables that are expressed in terms of numeric value. If you're trying to use logistic regression, you have variables that are expressed in terms of proportions. So if you're saying these residents in 5th year, in 6th year, in 7th year, you can express them in proportions, not in numeric value, for example. If you're talking about the Cox regression, then you're talking about time to events. So you must have an event and you must have the time. You must say this event happened at maybe day 3, day 4, day 5, day 6. That's the difference. Now, there's another thing that comes into consideration: univariable regression and multivariable regression. Each time you're doing a regression, you're doing it for 2 variables. So for example, here, our hypothesis was if we add a second resident, we can increase. Let me go back so that everyone understands here. Here it is. We said if we add a second resident here, we will have an increase in intraoperative complications. So if I do resident and complication, that's a univariable regression. If I do resident and procedure length, that's a univariable regression. Residents and patient length of stay, univariable. Those are three different univariable informations. Now, what I can do is come up with one equation with all of this, where I do resident, complication rate, procedure rate length, and length of stay. When I do all those three related to this one, that's a multivariable regression. So let's see what our guys used here. So they say it here, okay. The 4 outcomes, remember, the 4 outcomes of interest were analyzed for each procedure independent of other surgeries by multivariable linear regression with an acceptable alpha. So this p-value, the p-value considered was 5% determined a priori. Very important, you must determine your p-value before you do the analysis. And this is what they said, they decided. Now, what does this mean, the R squared? The R squared gives you the idea about when you've done the regression, you have the data spread and you can have a line around that. Now that line, you want to know if that line fits well. Does it fit the model? That's where you use the R squared. The R squared gives you an idea about how well fit it gives your data fits to that line, the line of regression. If it fits well, then your model can predict. It can predict certain things, because if in your model you're evaluating this, having a second resident with intraoperative complication, procedure, and patient length of stay, that means if you gave me this line, this multivariable line, you told me there was a second resident, you told me what the procedure length was and the length of stay, I can calculate the complication rate. So if you gave me any 3, I can calculate 1. Because there's a very good fit, because I checked the R squared. So this is the statistics here. This is the R squared. Okay, so now, before we go to the data justify the conclusions, now I'm getting off screen share and facing you guys so that we can talk about all those questions that were asked in the article. You guys asked, there was a lot of questions. Why did they choose 40? What were the limitations? Now we can speak about the limitations. You cannot go into the limitations, into the strengths, if you don't understand the study design, if you don't understand the statistics. That makes it very difficult to understand these things. Okay, so let's go. There are a few questions. Stefan is not here anymore, but he asked the question why they chose 40, and that was a very valid question. They chose only operations for which they had at least 40 interventions, or at least 40. What? So why?
I think it was to make to have a good sample size. I think it surely depended on the sample size.
Okay, so absolutely, you're absolutely right, but there's a problem. You shouldn't have to ask this question. When you're writing your paper, you should state it. You as the author should say, we chose 40 because, right? And this is how we came up with 40. Why 40? Everyone would ask the question, why? Why 40? But you're right, Zolo, very, very right. You're very right, because what you're trying to do when you do this, this sort of studies, what you're trying to do is you're trying to get your study to have enough power to give you the results you're looking for. And power is related because it's related to type 2 error. It's equally related to your sample size. Like you said, you're right, absolutely right, on the dot. So there's certain things you can't find for small populations. Let's take appendicitis and appendectomy. You decide to say, okay, I'm going to study appendectomies and study as operative outcome the death of the patient. What you need to understand simply is, how often do people die from an appendectomy? Not very often, right? So you need that many cases. You had so many cases to be able to detect just one death, right? So you need a very large sample size. But if you decide to say, okay, following the appendectomy, I would like to know how many infections of the surgical site we have. Those are more frequent, so you wouldn't need such a big sample. For the same study, choosing a different outcome, you have different things, and your interpretation is different. Same study. Same will go in neurosurgery. So you have patients that come for decompressive craniectomy, and you're looking for disability. Yes, disability are very common for operations that need decompressive craniectomy. So your sample size wouldn't need to be something crazy, right? But if you're studying something that's very exceptional during the decompressive craniectomies, then you won't be able to. You need much more. So they didn't say this, and this definitely is a problem. We'd like to know why 40. Why did they choose that, and how did they come up with it? They didn't say it. So that's a weakness. I've spoken too much, way too much. So Dr. Nourou, you can go with the discussion of what you said about the different weaknesses. I think we can use that now, if he's around.
Yes,
yeah.
It is a great session of discussion between you and your maths. It is good, and it is good what you've done. It is better. It is nice things to understand the value about studies, the value about what we made like studying, and that will be help you when you will start to write work and paper to publish. And it is very important to know all these basic things. And congratulations about this kindly and great analyze about the methodology of this topic. I'm sorry, I don't know why. Okay, my video is okay, good. Because I was done many things in the same time. So I'm sorry. So it is good. So like I told you, it will be nice. I think we have to present. I didn't. We have to present our when somebody have to present one article. It will be good to present one topic according those recommendations that you just discussed. Not just me. I don't know. If I know, I will summarize the article like this recommendation, and we will discuss that progressively. So it is okay. But about the discussion, I think I said what like you see in this article is good. It is good. It is good paper, but there are also limitation. But me, what I take out is what. Don't think that two residents in the same room to operate to perform procedure that will increase the time of procedure in all of procedure, because you have many procedures in neurosurgery, but just that they take, for me it is not representative. It's not really that can represent all we done in neurosurgery, like activity in operate room. Because sometimes you need more than one resident to help you to operate. Sometimes, because if you have a subdural acute hematoma, you and just one young resident, it's not in our condition. You don't have maybe craniotomy motor. You should perform 7 per hole. You should perform large bone flap. You should perform subtemporal craniectomy. You should open dura. You should evacuate. You should do like all that in short time. So you need help about young resident or senior resident. You need help. But what you have to know that is not always to put more residents in the same block, because you can increase risk of infection. So this study, it is good, but I think it is one paper who should help us to think more about our training, like resident. So what is better for us? Because you are resident, young resident, you just start your shift. You know that you have your learning curve because they didn't that's why I thought there is many limits in this study, because between young resident and senior resident and also somebody who finished his resident course, if you made correctly the job, the neurosurgeon who finished his residency course will have more ability and experience in their hand to operate some cases. In contrast, somebody who just starts who still in learn curve, because in neurosurgery you have learn curve. You can't avoid that. If not, you will make you have big problem in procedure. So you have learn curve that you should focus. For me, you can have a second trend of non-resident to resident in the same procedure. That does not mean you will increase time of surgery. No, for some procedure, it will be fast. For another procedure, it will, if you will compare when you just enter in block to do external shunt, like example, you will do that in 15 minutes, 20 minutes, you finish. But when you have another young resident with you, depend the skill. You should take time to explain him what are you doing, to let him to know, to learn. So you will take more time, okay? So all this aspect didn't take in consideration in this paper. So for me, in conclusion, it is good to have 2 residents in operate room. That is helpful, okay? But that is helpful. That is helpful. But because for me, for my example, when I am in shift with resident junior, he knows that I will come to operate with him. He should prepare the operate room before I come. I will come. He should do many things. Put patient on table. Prepare the head, pre-asepsy. Many things to do. Like that. When I will come, I will just verify if the position it is okay for me. If it's not okay, I will correct that and I will show him. Maybe I will lose 5 minutes or 10 minutes to correct him. But if I was in the same place with him and we have to prepare our patient before to operate, that will go so fast because I have more experience than this new resident, But me too, when I am in operate room with an assistant associated professor or the full professor, of course, he will let me perform my procedure to the brain, and he will come to do what he have to do. If you have to remove tumor, or if you have to remove to go to clip aneurysm, or many things. But we have learn curve in residency, so this notion should be mentioned in this paper. That is what I think. There is many limits. So and you guys, you aspire to be neurosurgeon. You just want to do laminectomy, just want to evacuate hematoma, no, or just want to do shunt. No, there is many things you have to do, many procedures. You want to do many procedures. You will see. First years, you have to achieve your goals. Every year, you have to achieve new goals, and it is like that. But when you move on, the goals that you achieved last year, you should have more affinity in your procedure second years. It is all that. But it's good things, it is good article that you choose. For you guys, I encourage you to really do your best to start your residency course now, guys. I hope you are clear with me. It is 5 years for residency course, but it's not, you should do more than that, because 5 years is not
enough.
Not enough. No.
Yeah.
I think you should do more than that. After your 5 years, you should do.
Yeah.
You should find one fellowship for 1 year or 2 years to do something, because neurosurgery, you have subspecialties enough. You have neurovascular, you have neurosurgery pediatric, you have spine surgery, you have school-based, you have many things. So I think you should take this paper with more. It is good for basic to know, yes, but for me, to resident, it is good to perform any procedure in surgery, because
I think we need to move on here. And thank you, Jenny. Both of you guys seem to have a firm grasp of statistics. Did you take a course in med school? Both of you seem to understand it. Took a course?
Yes, thanks, John. We're going to, let's wrap this, and then we can start with the lectures.
Yes.
So you're absolutely right. For the wrapping is I'll do this real quickly.
Okay, no problem.
So the very last question, because the other one is conflict of interest. Do the data justify the conclusions? It's very easy to get this. Why did I do all these explanations? Very easy. We just look at what we have. Okay. These are the descriptive statistics. I know no one will have difficulties here. 1 resident, 2 residents. Very simple. Now, these other statistics here, let me get to this first here. So like I was explaining, this is a multivariate linear regression analysis. So what are we comparing? Number of residents here, experience of most junior resident, interspace. Remember what we said. We're looking at an equation that relates all these things with the number of residents. And you have to take into consideration the p-value. So what they've done, they've put in bold all those ones that are significant. Look at the p-value. So this is 21%, 11, 58, 95. So what is significant? The procedure length, the room time is significant here. So what you do is you take this and then you go and see the interpretation. The coefficient, when the coefficient is negative, it means there's an inverse relationship. So adding a resident leads to negative coefficient. So adding a resident decreases procedure length in terms of posterior laminectomy. Look at it again, number of residents, room time, it decreases room time. That's what it means. So that's how you interpret this. So all you have to do now is go to the conclusions and see whether the conclusions make sense. You do the same thing here. Outcomes, you look at that. So for this one, cranies for hematoma evacuation, positive coefficient. Adding a resident increased the time, and you look at the conclusions. Did they conclude only based on the population they had? Did they exaggerate? Did they extrapolate? And then you have the answer. So this is why you need to know the statistical methods. This is why you need to know about the study design, so that you're able to know whether these studies make sense. And absolutely, you need the experience. Thank you, Dr. Nourou, for explaining very diligently why you need to take this with prudence, because like you said, the young guys need to learn. You have to think about the patient that's on your table, but you equally need to think about the future patients. If the young guys don't learn today, then the future patients don't get quality care. So very important.
Okay, we're ready to wrap this up and then move on to the next presentation. And thank you very much, Nourou, for starting things off. I'm sorry, we're kind of in the woods about statistics. I couldn't add anything to the discussion. I had known absolutely nothing, but it seems to be a valid area. At any rate, thank you, Nourou, and we'll just end this presentation formally. Thank you.
We're going to.
I'm just stopping it now. Well, I'm gonna edit it, and we'll just we'll have 3 separate ones.
Okay, makes sense. Zolo is next.
John?
Yes, go ahead.
No, I'm sorry, if you just allow me, I just want to share you my to share with you just to the people who there, but I think all of them know this article, so it is okay. I will just to share my 2 news articles that I just published recently about. Let me show you quickly, just 1 minute, guys.
Okay.
I don't know, can I see
You took a
that?
statistics course, Nourou, during medical school?
Yes.
Oh, you did. That's part of the curriculum now, huh?
But it is go. I'm sorry. Okay, so now I think we will go for presentation of Ulrich and Zolo. All right. Okay. Can you share my? I don't know.
You're not
okay.
screen sharing. You're not able to screen share.
Yes, it is okay now. Okay.
Okay.
So I don't know if you can see this.
Yes, we can see it. We can see it.
Yes. So this it is one of paper that I recently published about intramedullary cavernoma. You can see that, and go to read that. It was on cases report. So I just want to show you, John. I will send you the PDF, and this it is the second another article that I just published again. It is on user site about small cell osteosarcoma.
Oh, okay. So you wrote the paper. Wow. That's how you know statistics, huh?
Yes. So you can see that these 2 cases. This is what I made. So it's just to show you, John, and I will send you that you can share that. So it is okay. We can go ahead now.
Okay.
Thank you for.
Okay, we'll just wrap this up formally. I'm going to edit it.
I think I will